All right. Let's go again with the polycythemia. And remember that we have polycythemia vera, neoplastic transformations of the bone marrow stem cells, absolute increase in the red blood cell mass, leukocytosis, thrombocytosis, increase in uric acid because the excess of proliferation of the red blood cells, oxygen saturation is still normal. The main problem with this, you already have an idea, is this, especially if that is a cardiac patient, because the increase in viscosity will increase in blood pressure, something that everybody needs to know for this moment. Anything that increase the volume, anything that increase the viscosity can increase the blood pressure and put that person in huge problems. Now, the reason that I make this one over here is because I will go with the same question that you saw last week about polycythemia. I put it a couple of times and the people still don't get it, meaning that I will go with the same particular questions against about polycythemia. The secondary polycythemia, very important indeed. Don't confuse this one with the previous one. That is another common mistake. Here is very clear what happens is the increase of erythropoietin production that will increase the production of red cells without the increase of the white blood cells of platelets. Identify and manage the underlying cause of hypoxemia. Phlebotomy may be used to decrease the cardiovascular workload, and the prognosis depending what is the condition in that particular patient. But I need to ask you for this one, that's why I leave it over there again. And the relative polycythemia caused by dehydration with a spurious increase in red blood cell production, and you had two types of groups over there. The one, because the fluid balance and the stress of polycythemia also, elevated hematocrit, also hemoglobin, and red blood cells count. Okay, careful with that one in particular. Now, jumping now to another chapter. You see how I'm jumping over there? I'm just going exactly what you have over there. Yes? Somebody had the microphone on? Oh, sorry. I thought that they would make a question. I don't have any problem with that. But don't let me waiting. Okay. Factors 7 and 9 and 10, protein C and S, are the famous dependence of the vitamin K over there for synthesis. That was a question that I did over there, and many people fell for that one. Careful with that question, and I need to ask you for that one again. That is the reason that particular PowerPoint is there, because I will go through that particular information again. Very important to remind you, who producing those factors over there? You already know. The liver are the one who produce those factors over there that are important for you as the anticoagulated factors over there.
You can hear me?
Oh, yes, and you leave me basically deaf, but it's fine.
But I can't hear him.
You cannot hear me? You can send me a text message by the chat box over there. All right. Good. Very strange. Everybody can hear me, correct? She cannot hear me for some reason. Probably she have a problem with the microscope. Sorry, with the microphone. Okay, let's go over here with the process of homeostasis. Yes, this is what I think. That she have a problem with the volume somewhere. Now, let's go with the fibrin clot. Intrinsic pathway initiated with the blood comes in contact with the arterial vascular endothelium, and the extrinsic pathway begin with the vascular wall is traumatized and crush injury. You already know why I ask you this one. Oh my God, I cannot hear myself now. Fibrin clot. Remember, intrinsic pathway initiated when the blood comes to a contact with the arterial vascular endothelium, and the extrinsic pathway begin with the famous vascular wall trauma crush injury. And that was an interesting answer to a question that many people felt, meaning that I will go with this one again. Careful with this particular question because it's there again for second occasion, okay? In the fibrinolysis, the clot dissolution, that many people also fell out of guard with this question because I told you that this was the primary sequence in the cascade. In reality, this is the last part of that cascade, meaning that careful with that again. I will try to make sure that you understand a little bit as possible how this particular coagulation factor works and the cascade is working over there, okay? Meaning careful with that. Is there is because there is a question associated to that. Not everybody will get the question because I have some variants of the question, but you want to make sure that you will not encounter some kind of, dwarf making some kind of damage in your test. Make sure that you read that presentation in case that you encounter that question. Now, thrombocytosis, again, I put this one to reinforce what is the reason that you need to remember that value that you have over there. Anything above 400,000 millimeters over there cube is what is thrombocytosis. You can have transitory because the stress of physical exercise. You can have primary because polycythemia vera or chronic granulocytic leukemia, or secondary in response to a hemorrhage and disease process of splenectomy too. But I put this one over there mainly because I want to remind you of the value and the range of thrombocytosis. And many people saw a number bigger than that and they said that basically was thrombocytopenia. No, basically try to fix that mistake in case that you see that question in your test next time. And it's there because I went with the same similar question that you saw last week, okay? No, I put this one mainly as one is making a question if I want to know the primary, transitory, secondary. No, I leave this one mostly because the value. I have an interest first in the value. For me, it's indifference what is transitory, primary, and secondary. So you know what is the value and the normal value of thrombocytopenia, thrombocytosis on the normal amounts of platelets in your body. It is clear. Let's move on to the next one. Hemophilia, you already know that I asked you something, and that is the reason that I put this one again. And this is one of the most common inherited coagulation. Reason why I ask you for this one, okay? Disorder resulting in excessive bleeding, hemophilia A, hemophilia factor 8 deficiency, hemophilia B, Christmas disease factor 9 deficiencies over there. And because I saw many people still struggling with this particular hemophilia, and because it's one of the most common, that's why I am redoing the question again in some of the tests. Not all the people will get the same question, but there is a question of hemophilia, okay? Let's move on. This one is another one that created me a lot of headache because not only I ask you for the definition and to explain me what happened in the DIC, then I came out in the quiz, I ask you a multiple choice and they don't know how to answer me the question about this particular disease. Reason why, guess what? I will ask this question again in different format, but that is the question related over there to disseminated intravascular disease. Very important for me because it's something that you can see very often in the hospital with this particular person that has some particular infections, especially in gynecology. Okay, with that one is there. You need to be careful about that one. Now, what happened with the DIC? This is what happens. Fibrinogen levels and platelet count decreases, increasing the bleeding time, elevated PT, INR, and PTT, and very characteristic, elevated D-dimer fibrin split products over there. I like to put in the particular case in some of the questions this information to basically building up the case study, meaning that if you see some of this particular data, you already know, or you need to imagine that basically asking you about disseminated intravascular coagulation. Again, the treatment Yeah, the reason that I ask you for this one is because this. Fresh frozen plasma, similar to hemophilia in that particular case, pack of red blood cells, platelet, and cryo precipitates over there. That is the only reason that I put this particular PowerPoint over here. I don't go with some controversial thing. I will always go with what normally we use always in these particular scenarios. That's why I'm careful with that particular treatment in specific, okay? Now we are jumping to another chapter, as you see over here, that I'm jumping just directly where I want to go. And we are reaching to the blood vessel, especially the obstructions. Remember, the obstruction could be arterial or the venous system too. The obstruction is reduced flow beyond the obstruction down the stream on increased pressure before the obstruction upstream. In the arterial system obstruction, you have distal ischemia. In the venous system obstruction, you have edema. That's it, the very difference between these two. Careful with that difference at the end. Sometimes many people don't understand the concept and they basically choose the wrong answer because they are not reading completely the concept. Careful with that. The thrombosis, I will ask for this one. Exactly what you see over there, you have a multiple choice just for this. Meaning, you need to know the causes of thrombosis. You need to know what is a thrombus. You need to know that the arterial thrombosis results in ischemia, that the venous thrombosis results in edema, and the inflammations in the veins is phlebitis, and the inflammation with a clot in a vein is thrombophlebitis. Careful with that. It's very important that you remember all this particular thing because there is a multiple choice with thrombosis. And basically continue with the next one. The clinical manifestation also important for me, meaning careful with the clinical manifestation right now. That is where I will try to build that particular question in your test. Arterial intermittent claudication, cool cyanotic painful ulcer around one toe. The venous one, no life-threatening pulmonary embolism, calf growing tenderness, swelling, and Hoffman signs over there that I will explain that one later. But careful with those manifestations in arterials and venous systems over there, okay? Moving on to the next one. In atherosclerosis, there is another multiple choice, very similar to something that we saw recently. And you have the pathologies, but I will not go with the pathologies. What I will go over here is with the development of this particular situation in the human body that develops in the mediums and large size arteries. And a process, basically, that you have it over there. The initiation is in the damage in the endothelial surface, in the arterial intima, and the inflammatory response that will follow that will continue making that damage inside of that particular vessels. Meaning it's here that you need to pay your attention, not here right now, okay? Now, in the atherosclerosis, careful with this. We saw this one in class. I explained you a little bit about this. Low densities, zero lipoproteins, breach the intimal layer, leukocytes and endothelial cells, oxidize over there. The lipid producing further damage. Simultaneously, then the platelets start to show up to that place and start to deliver those growth factors that stimulate the smooth muscle cells to grow beyond that normally the area they're supposed to be. That basically will increase the obstruction inside of that vessel. Careful with that one, very important indeed, because exactly what I did recently, that I will ask you what is the order of the problem of atherosclerosis. I am doing the same thing with atherosclerosis, okay? The result of atherosclerosis, you already need to remember that. A plaque, I need to advise to you, careful with this one. The two questions very similar with this particular, basically PowerPoint and information over there, especially with the plaque. Enlarge, slowly enlarge the orifice of the arteries is decreased and perfusion is diminished, can lead to hypertension, cardiac coronary artery disease, and renal disease, peripheral arterial disease, and stroke and myocardial infarction. Meaning that is a question exactly like that in your test. Make sure that you read this one, and if you don't understand some of the concepts over there, or you want to know more, remember you have the textbook over there, and you can go back to these particular PowerPoints. You already have the PowerPoints, and you can go in more details over here. Okay. I always like to ask you about the modified risk factors because believe it or not, I have a bunch of you guys that still have some kind of problem with the risk factors. In this particular case, obviously, tobacco is the number one cause of these particular problems because injuries the endothelium, elevate the LDL cholesterol triglyceride, decrease the HDL, produce vasospasm, increase platelet aggregation, increase blood pressure and heart rate, increase risk of coronary heart diseases. Cessation of smoking is what we are looking for over there. That's why we need to be extremely careful with this. I always make you some kind of question with this one. That's why it's there. The modifier risk factor, the one that you can modify, hypertension, cholesterol, lipoprotein, triglycerides, this particular thing that you can basically follow a diet, follow a beautiful exercise, a topic over there. You can modify them over there. Glucose intolerance, metabolic syndrome, and diabetes increase risk, obviously. And the obesity, obviously, will accelerate the atherosclerotic process. Very similar to the question that we did in this particular one. Moving on over here. In the identifications and intervention directly toward the modified risk reduction, physical activity increase the HDL, collateral circulation, the vessel size, decrease the total cholesterol levels, include intolerance and body weight and blood pressure. That is the reason that the physical activity is one of our first tools to manage this particular patient. Stress and mental health also. Stress and depression can increase the risk. And the particular risk that cannot be modified, you have it over there, please. Careful. Many people still have some problem with those particular factors that cannot be modified over here. Now, a question that showed up recently in this past particular quiz, and that was the answer, deep vein thrombosis. Many people fell for this one. Most frequently because the thrombus in a deep vein of the lower extremity may be asymptomatic, treated aggressively with the anticoagulation therapy. Previous DVT, believe it or not, is a risk factor for further hypercoagulation. I have something similar. It's not the same question. That's why I put it over there, meaning that pay attention to the first three bullets over there. Yes, I think that is the computer or somebody that have problem with the microphone or the volume. All right, let's move on over here. In the arterial blood pressure, I am jumping again. For some reason, in that question that I did last week, or basically this week, many people still have some problem where is the determinants of the systemic blood pressure. Remember that we need to understand what the blood pressure is. Cardiac output multiplied by that systemic vascular resistance. You have it over there. Many people, for some reason, thought that was the heart rate. No, that is cardiac output. Multiplied by stroke volume, you will have the cardiac output, and the cardiac output multiplied by the systemic vascular resistance, we will give you the blood pressure. I will do the same similar question, meaning that careful with this slide. You need to know that it's essential because one of the things that you always need to do when you receive a patient is to take the blood pressure. And if you don't understand the concept very clearly over there and what is trigger the basically the blood pressure, we will have a problem over there. Let me see that somebody over there have some problem with the audio. I will put something in the chat box over there. Computer. All right, then move on over there. In the short-term regulations of the systemic blood pressure, well, let me see. Sorry for the parenthesis, but somebody has still has some problem. Is missing right now. I'm sending a message to Jones over here right now. Okay. Meaning that is local. Is your system. All right. Everyone is listening to me right now, meaning it's your system. This is what I want to say to the person, meaning that they need to look in the computer what's going on. All right. Let's go back. Remember, we mentioned this one in one of the particular quizzes, and many people became a little bit confused because they thought that the long-term regulation is the first thing that will happen. No, that is the reason that is the long-term. When the body wants to regulate his blood pressure, we have short-term regulations of that pressure. Any change in the blood pressure will activate, obviously, to the sympathetic nervous system first and will result in the release of neurotransmitter epinephrine and norepinephrine. And the parasympathetic nervous system is the one who slows down this. Careful with that because many people confuse this. Now, in the short term, one of the things that we have is the famous baroreceptors that we mentioned before, which monitor the means arterial blood pressure. This is what will activate the receptors in the smooth muscle of the arterioles, create a vasoconstriction that will increase the systemic vascular resistance, and at the same time activate the beta receptors in the heart and increase the heart rate. As you see over there, this is short term because this happens too quickly. Now, the chemoreceptors also stimulate the medullary or medulla oblongata in the brainstem to increase the sympathetic nervous system activity. And these fellows are located in the aortic, arterial, carotid, and aortic arterial areas, and only will show up when the blood pressure is extremely low. That's why many people confuse these ones over here in the question with these ones. Is this a short-term regulation? Is this one that I need to pay attention? Is this something that will take a longer? Is the below ones. Careful with that difference over there because I will mention this one now after these PowerPoints too. See? In the long term, this one regulated by neural, hormonal, and renal systems over there, connected fluid volume, increase in the extracellular fluid volume, increase in cardiac output, increase in that beautiful what? Systemic vascular resistance that will elevate your blood pressure. Will cause the kidneys to excrete huge amounts of sodium and fluid, increase in serum sodium levels, and increase osmolality. Remember, if you increase the sodium levels, you are reabsorbing water. At the same time, increase the ADH secretion because the kidneys need to preserve more water over there. Careful with this one because that is the difference between short, and versus long term over there. Yeah, I will do a question. There is a question regarding that. Here in the lung is what you see the famous renin, angiotensin, aldosterone system. And everybody more or less remember this one very well. I didn't ask you anything indirectly last time. I just asked you about the ACE inhibitors. But in this time, you need to remember that the long-term regulations of the systemic blood pressure is highly related with this particular system. That's what you need to remember. And what is the finality? Increase your blood pressure. That's what you need to remember. Then we jump to hypertension. I did this question And believe it or not, I have some people with some doubts about this particular primary hypertension because in the test I mentioned that this one is idiopathic and sometimes over here also called essential hypertension. And many people have some difficulties to remember that. Meaning, make sure that you review these slides again because I will go with the same kind of questions again. In the risk, because they are the same one, I don't think that I will be proper to remind you this one again, just for this time, just to reinforce, make sure that you don't confuse the non-modified one with the one that you can modify. That is the only thing that I will emphasize in this particular PowerPoint. Okay. Now, the primary hypertension in this particular slide, the reason that I leave it over there is because of this. The end organ damage. The damage that can happen inside of your body, renal failure, a stroke, heart disease, damage to arterial system, accelerations of atherosclerosis that lead to cardiovascular disease, the increase of myocardial work in heart failure, the glomerular damage resulting in kidney failure, and the microcirculation that is affected in your eyes. That is the reason that I need to ask for this because this is essential in the management of high blood pressure. And there is a question obviously over there. Now, in the secondary one, the reason that I ask you for this one, you already know because I mentioned this one in the class several times. It's most common form in infant and preschool children, and is the most common cause of for childhood. Obviously, is renal disease and the coarctations of the aorta. That's why I need to ask you for that. In the mechanism, yes, I need to ask you that. It's very similar because this is related to what we saw before in atherosclerosis. And just to reinforce what you need to know, that's why I leave these particular PowerPoints over there. But it's basically very similar because everything starts with that beautiful what damage that you encountered inside of the vessels and the accumulations of that LDL over there. Meaning very similar, but please review this information to avoid any kind of what confusions in the question how you read it. That is my only worry over here. Let's move on. Again, the macrophages engulf the lipids, became engulf foam cells over there, release inflammatory mediators and growth factors, attracting more leukocytes and stimulating the smooth muscle proliferation. The excess of lipid debris accumulated within the vessel wall and collapse into a lipid core over there. Over here, I will suggest to go with the first one because it's the one that increases the proliferations of that small muscle that basically will start to create that obstruction inside of that particular coronary artery. Okay? Careful with that first bullet over there. Is where basically correlate with the question in the test. In the mechanisms of the coronary arteriosclerosis, this is what happens over here with the plaque. That's why I put this one over here. These two are the most interesting thing to answer that question in the test, meaning there is a question related to a plaque. Make sure that you review these particular concepts over there because they will show up in that particular question. Vulnerable plaque may rupture or erode and which stimulate clot formations of the plaque. Vulnerable plaque have large lipid cores, thin cap, high shear stress, meaning careful with those two. That is highly related with that particular question in your test, okay? Moving on. In the increase of the plaque vulnerability, yes. That is something that you need to know, and it's also related to the previous slides, and that is the reason why I leave it over there. Meaning, read it. You need to read this one because it's basically going a little bit in deep from the previous one, and it's related to the same. In the pathophysiology of the ischemia, you already know that we are basically repeating this one from the beginning of the particular session. I put it over there just to remind you again about the ischemia and the problem what happened with the oxygen supply to meet the metabolic demands of the heart. The, the critical factors over here, obviously, is the rate of the coronary perfusions and the myocardial workload, but please, this is essential for me and the question is related to this, okay? Especially that first bullet over there. Now, the coronary perfusion can be altered by, yeah, I need that question. Large stable atherosclerotic plaque, acute platelet aggregations and thrombosis, the vasospasm, failure of autoregulation by the microcirculation, poor perfusion and pressure. Those particular concepts need to be clear because it's part of the pathophysiology of the ischemia, okay? If there is a chronic occlusion of the coronary vessel, is what we call a stable angina. But that particular bullet over there, the first one, essential. Now, in the acute occlusion, you already know what will happen. The plate disruption and thromboformation and resulting in stable angina or myocardial infarction. Myocardial ischemia may be commonly because by coronary spasm, hypoxemia again, and low perfusions over there. But again, for me right now in the test, careful with the first one. In the chronic syndromes with low progression, because the chronic syndrome from a stable atherosclerotic plaque, you will see the famous stable angina pectoris. Many persons will confuse this one with unstable. That's why I leave it over there to make sure that you don't fall for the trap and you think that this is unstable or can provoke an unstable angina at the moment. If it is chronic with a slow progression, we are talking about a stable angina pectoris. Okay, careful with that. Now, we have the famous acute coronary syndrome that I know that many of you have some kind of difficulties to understand the concept. But remember that, first of all, associated with acute changes in plaque formology and thrombosis, and can basically be life-threatening in this particular patient because then you have an unstable angina and even a myocardial infarction. Any of the coronary heart syndrome may precipitate in sudden cardiac death and associated dysrhythmia. Even that I don't ask you for this one in the test, you need to assume that always in this particular patient. And careful with this in your test because I will do reference to this one particular quote. In the angina pectoris, I leave it over there, but I am repeating myself, and it's especially because the symptomatology that it presents this particular patient. That first bullet over there, burning, crushing, squeezing, choking, refer pain over there. Many of the patients can think momentarily that what they have is a myocardial infarction, but it's not. Okay, careful with that first bullet over there. That is the one that I have interest to basically correlate with that particular question in the test. Okay, moving on. Mitral stenosis, for some of you, this was a question in the last quiz that we have in this quiz, and many people failed badly with this one because this was basically the answer to that question, and many people confuse this one with the aortic or with the regurgitation of the vessels over there, meaning careful with this one. I will go with something similar again because this is important. You're supposed to make the approach to the patient with your stethoscope and try to listen those sounds. They have these particular problems and valvular diseases, meaning mitral stenosis. This is what you hear. Okay. Careful with this one again. Some of you will have these questions. Some of others will have the aortic. Some others will have mitral regurgitation, meaning it's important to go through these ones. The aortic stenosis, the most important thing for me right now is these two. Left ventricle hypertrophy may result in ischemia and left side heart failure. The crescendo, decrescendo, the famous murmur during ventricular systole with a prominent sound S4, syncope and fatigue and angina could happen to these particular patients. Okay? Meaning, in this slide, pay attention to those last bullets because it's important for me to remember. In the myocardial diseases, you have over there the dilated cardiomyopathy. This is a cardiac failure associated with dilations of one or both ventricle chambers. Maybe alcohol toxicity, post-viral myocarditis, genetic abnormalities. But what I want over here to remind you is the first bullet over there and the last bullet over there. Okay? This is what basically can create this cardiomyopathy more evidence. The slow progressions of the biventricular heart failure with low ejection fraction and the cardiac failure associated with dilations on one or both ventricle chambers. Careful with that, okay? Moving on. Another thing that many people, for some reason, in one of the first quizzes, I don't know if they are looking somebody else quizzes and became confused with the hypertrophic cardiomyopathy. Remember, this is very important because these particular patients always will show defects and problem with the blood pressure too in the beginning. Then you will see all the symptomatology that they will show up. Genetic abnormality pattern can show up, clinical causes variable, typical slow progression. They can have a symptomatic dyspnea or angina and they don't know that. Meaning, careful with this one. I have something related to that in your test. You already know that this one was an answer to this quiz in this week. Many people get it, other people not. But that is the reason that I will put it again. Especially I won my first bullet over there. Okay? Cardiac tamponade, when the fluid accumulations in the pericardial sac is large or sudden, it can lead to external compression of the heart chamber such that feeling that is impaired. Remember that the heart is basically surrounded by that pericardial sac. And if there is some kind of hemorrhage of accumulations of fluid in that bag that engulf the heart cannot basically contract and recoil normally, creating this particular issue. Meaning that that first bullet over there, and by the way, this is basically what I asked you in part 2, the manifestations of that particular situation. But in this case, again, careful with that is what basically can be hanging again in your test next week. Okay? The tetralogy of Fallot, you already know that I asked you for this one. Many people answer me correctly the first part, but they forgot that it's cyanotic, not acyanotic, meaning avoid to commit that mistake, meaning that I will go again with the first bullet over here of the 4 defining features of the tetralogy of Fallot again. Careful this one, you saw it this week. I will put it over there again somehow, or a little bit this guy with something else. Careful with that one. Then we enter to the heart failure. The heart failure, I ask you for this one in a multiple choice also this week, inability to maintain enough cardiac output to meet metabolic demands of tissues and organs. Some of you confuse this definition with cardiogenic shock. Careful with that. We will see those shocks soon because I will ask them again. Now, careful with the definition. And obviously result in what? In blood flow in the systemic or pulmonary venous circulation, inability to increase the cardiac output to meet the demands of activity or increase the tissue metabolism. Meaning, in this case, please give me those two. Those are the two that I want in this case. I will go with something similar, not exactly the same question. Some people will have a tiny variance in that question in the test. The heart failure is a potential consequence of most of the cardiac disorders, obviously. What is the most common that you need to remember that I ask you some of the tests, this particular question? This. Meaning, please, careful with this one. You cannot leave behind this information in particular because this is something that will hunting you out in the core. Meaning, I will ask that question again related to that particular area of the heart failure. In the systolic dysfunction, the most common myocardial infarction is the most common etiology. That by himself could be even a true or false over there, but some people could have a
Can
basically
you hear
a
me? Can you hear me?
yes, I can hear you and everybody else. Myocardial infarction is common etiology. Reduce the contractility, evidenced by a low ejection fraction and reduced inotropy during ventricular systole. Impaired contractility involves loss of the cardiac muscle cell beta receptor downregulation and the use of ATP production. Okay. Again, careful with these two. I need the first two in this particular PowerPoint. Essential for me that any nurse to be remember this one because it's important for me that you remember this one always. Okay. Now we are reaching the top of the hour. I will do another 5 minutes break until to see if some people that have problem with the microphone can fix the problem. I will stop over here the recording right now and try not to overload the file enough that will be more easy to upload later on in YouTube.